thank you very much for the invitation to give this talk, and thank you for joining me. I'm Yoni Buber. I'm one of the adult congenital heart disease attendings, and also a member of the multidisciplinary thoracic aortic program that we have here at the University of Washington. This is going to be the outline of my short talk. I'm going to discuss a little about our clinic, what patients we see, where it is located, what we look for. And then I'm going to go into a little bit more detail about patients with select genetic aortopathies that we see in clinic, meaning Marfan patients, vascular Ehlers-Danlos, and Lewy-Dietz syndrome patients. Speak a little bit about the medical treatment and then timing of surgical interventions in those patients. And so this is kind of the entrance to our clinic at the University of Washington. This is the door. It's located at the lobby on the third floor, and it's really, right next to the entrance. So once you make your way into the hospital, it's like 10 steps away, and you're in the clinic. And these are the type of patients that we see in our clinic, and we grossly divide them into syndromic aortopathies and non-syndromic aortopathies. And there is some overlap, of course, between those two groups. But in general, for the syndromic aortopathies, we would see the patients with Marfan syndrome, vascular EDS, Lewy-Dietz, Turner syndrome, and other less common syndromes as well. And for the non-syndromic aortopathies, we would see this larger sack of diseases that is called heritable thoracic ascending aortic aneurysm disease, or HTAD. Some of you may be familiar with the acronym FTAD. F is for familiar, it's the same thing. The bicuspid aortic valve patients, which is kind of an overlap between my aortopathy hat and my congenital heart disease hat. It's a pretty common condition, as many of you know. About 4% of the population goes along with aortic dilatation. And then not infrequently, we would see patients with other type of aortopathies as well. In the general population, the most common cause of aortopathy is actually hypertension. And so we would see those patients who are being referred to us with dilated aortopathies because of hypertension, high cholesterol levels, diabetes, etc. So the classic risk factors for atherosclerosis and cardiovascular disease. And so these are the patients who we see. And I think that the key to the success of our clinic and the way that it works so well is what you see here, which is the multidisciplinary approach and the collaboration between those four arms that you see here on the slide, namely the cardiologists, the imaging experts who help us interpret the CT and the MRI images, the cardiac surgeons and the vascular surgeons, and the geneticists. And it's not that each patient that comes to see us needs to see all four clinicians at the same visit. It's rather an individually tailored approach. So we were happy to see patients, but we refer patients on an as-need basis to the other modalities or the other specialists. It's a very, very individually tailored, structured approach that we use in our clinic, and that makes it, again, very successful. What do we look for in our clinic? So what would each of the patients who would come to see us kind of get, and what questions do we ask them? And so the first and foremost important question is symptoms. How do the patients feel? What do they do for exercise? Do they have any symptoms when they're exercising or when they're resting, and so on? And then we take kind of a deeper dive and look at the dimensions of the aorta with some imaging modalities that I'm going to go over in a minute. We're going to look for other blood vessel involvement and not just the aorta in certain types of aortopathies. We look at the function of the heart itself with an echocardiogram. We take a meticulous look and measure the blood pressure. We look for other body system involvement, of course, the eyes, the lung, etc. We have long conversations about exercise recommendations and about avoiding risk factors for cardiovascular disease, such as diabetes, smoking, cholesterol, etc. In terms of the imaging modalities, we mainly use two modalities. The first one is the echocardiogram that you can see here. So on the left-hand side of this slide, you can see what we call the peristernal view, in which the probe is placed lower on the chest wall, and we get the root of the aorta, which you can see on the bottom left side of the slide, next to the letters AO, and this provides us with a good measurement of the aortic root on the echo. And then on the right-hand side of the slide, you can see what we call the suprasternal notch view, in which the probe is placed kind of on the lower side of the lower edge of the neck, where we can see the aortic arch and the descending aorta. And so the echo provides us reasonable to good views of those areas, and we use that as a screening measurement. But obviously the more accurate views are provided with what we call cross-sectional imaging. So those would be the CT or the MRIs. And here's like a very nice example of how beautiful our pictures that we get of the aorta can look on those imaging modalities. And the measurements that we make can be done from different views and different angles. So on the left-hand side of this screen, you can see what we call the coronal views of the aorta. This is just one angle where we can get the measurement of the root, the ascending, and the aortic arch. In the middle, you can see kind of looking down the barrel of the aorta at the level of the aortic valve, which is another great way to measure the aortic dimensions. And then on the right, you can see what we call the 3D reconstruction that shows, in this case, an aneurysm of the aortic root. And so the cross-sectional imaging are used very frequently and are probably a little bit more accurate, we think, than the echo itself to provide the measurements of the aorta. And I'm putting this slide here not because The Princess Bride is one of my favorite movies of all times. I'm putting it here to make the point that aortic dimensions is not like an absolute value only. It also should be tailored to a patient's body size. So, you know, a 4-centimeter aorta or 4.5-centimeter aorta would not be the same thing for little Vizzini on the left as it would be for physique here on the right. And the way that we tailor and we individualize those measurements would be through what we call the Z-score of the aorta. And you can find how to do that on the website of the Marfan organization. There's a readily available calculator. And I do that 2 to 3 times per day. We just punch in the numbers and then you get the Z-score. And you would see that Z-score as part of the imaging report. So let's move on into like specific conditions that we follow in clinic. And the first one would be Marfan syndrome. And this is what we call the Marfan checklist. So all of the patients with Marfan syndrome who would come into our clinic would get those things. And we start, of course, with imaging of the aorta with either an echo, an MRI, or a CT. We are very, very meticulous about making sure that our patients' blood pressure are below 120/80, and we use medications, as I will show in a minute, to make sure that this is the case. We provide exercise recommendations and dietary recommendations to make sure that the patients do walk around with the blood pressures that we want them to have. We make sure that our patients not only see us, but also see the ophthalmologist and other providers from other fields of expertise, such as orthopedics, pulmonary, etc. We discuss exercise restrictions, so we make sure that our patients know what they're allowed and not allowed to do. We discuss other medications. And then for individuals who are interested in family planning, we usually have long conversations. And there's also a separate clinic, which is called the Cardio-Obstetrics Clinic, in which we provide preconception counseling to patients who are interested in family planning and have Marfan syndrome. In terms of medications, we're looking at two main classes of medications in Marfan syndrome. Those would be, of course, the beta blockers and the angiotensin receptor antagonists. The beta blockers reduce wall shear stress and aortic growth rate, and they're the recommended class of medications for patients with high blood pressure. And then the angiotensin receptor blockers work on the TGF pathway, which is an important role in the pathogenic aortic dilatation process. And when possible and when feasible, those two classes work very well together. And so for patients who can tolerate them and have good blood pressure, we recommend both beta blockers and angiotensin receptor blockers. When do we start speaking with our patients about prophylactic aortic surgery? So we have the American Heart Association and we have the European Society of Cardiology guidelines to help us make those decisions, which is always, kind of the biggest conversations that we have with our patients in clinic. And so these are the recommendations, and in both sets of recommendations, the cutoff is 5 centimeters, as many of you probably know. The American Heart Association also say that if there is a fast growth rate of more than 5 millimeters per year, or if you have an indication for a valve intervention, for example, or if you have a family history of a dissection at a diameter of less than 5 centimeters, then that threshold should be lower. And in someone who is looking to become pregnant, that threshold is actually 4 centimeters. The recommendations by the European Society of Cardiology are kind of less strict for patients who want to become pregnant, and they use 4.5 centimeters as a cutoff. And so this would be kind of a busy slide, but this is the algorithm of our follow-up in patients with Marfan syndrome in our clinic. So we start with a baseline CT, echo, or an MRI. And if the aortic diameter is less than 4.5, and if it increases by less than 0.5 centimeter per year, then we follow up with an annual echo and MRI. We usually alternate. If the diameter is between 4.5 and 5, then we do a 6-month follow-up. And if it is more than 5 centimeters, or if it increases by more than 0.5 centimeters per year, then we refer the patients to see the surgeons. And of course, the cutoff is different at 4 centimeter cutoff in patients who want to become pregnant. Moving on to Lewy-Dietz syndrome. And so Lewy-Dietz syndrome is a widespread aortic and arterial aneurysm and tortuosity condition. And so it's not just the aorta that we're screening all of the other vascular beds as well. This is the Lewy-Dietz checklist, which is kind of similar to the Marfan checklist, but we use more frequently MRIs and CT again to look for those other vascular beds and not just the aortas. And we do refer to other providers because there are many other conditions that I'm not going to touch on in patients with Lewy-Dietz. In terms of medical management, the data is much less robust for angiotensin receptor blockers and beta blockers in these conditions. We do recommend them for blood pressure control, but again, the data is not as strong. We do want our patients to have good blood pressure again, especially in Lewy-Dietz because of the tortuous and aneurysmatic blood vessels that are not just the aorta. So blood pressure control is extremely important here. And those are the indications for prophylactic surgery by the American Heart Association and the European Society of Cardiology. We use lower cutoffs for Lewy-Dietz, 4 to 4.2 on echo, and 4.4 and 4.6 on a CT or an MRI, which is maybe the room to make the point that we usually get slightly larger measurements of the aorta on cross-sectional imaging as compared to echo. The European Society of Cardiology guidelines are kind of less they're less accurate. They don't give us those cutoffs. They say that we should treat that condition in patients who have Marfanoid manifestations, which is kind of a very general statement, and use the Marfan thresholds for aortic replacement. And so we, of course, based our decisions on the American Heart Association guidelines. And then finally, vascular EDS. As many of you know, that's a condition that involves other vascular beds as well, especially the intracranial, so inside the skull, carotid vessels, cervical vessels, but also abdominal and renal arteries. Those patients have like easy bruising, poor wound healing, and importantly, involvement of other hollow organs, such as the intestines and the uterus. The EDS checklist in our clinic is almost identical to the Lewy-Dietz checklist. So the same things, tight blood pressure control, imaging with mainly CT and MRI to look at the other vascular beds, etc. There is some good clinical data on beta blockers in vascular EDS as compared to Lewy-Dietz, where the data is less strong. And so we use beta blockers in all of our vascular EDS patients for the same reasons that we use them in Marfan patients, again, reducing the wall shear stress on the aorta and the other blood vessels. And, unfortunately, both the American Heart Association and the European Society of Cardiology guidelines do not specify like a certain cutoff for prophylactic root surgery. So we use similar numbers that we use in Lewy-Dietz, around the 4.2 cutoff as well. And so this is our algorithm for imaging follow-up in patients with low EDs and early stage vascular early stenosis. We again, for the aorta, we start with an echo, CT, or an MRI. If the aortic dimensions are less than 4 centimeters, or if they increase by less than 0.5 centimeters per year, we do annual echo or CT or an MRI, we alternate. If it's between 4 and 4.5, it's every 6 months. If it's more than 4.5, or if it increases by more than 0.5, we refer them to the surgeons. The indication for root surgery for women who desire pregnancy, they're not very clear. They're not, the recommendations are not very strong, but we use anywhere between 3.5 and 3.7, which is a pretty low cutoff. And then we, as I mentioned before, we don't only screen the aorta, we screen other blood vessels or other vascular beds as well. And so for those, we usually use MRAs or CTs. If there is evidence of any vessel tortuosity or aneurysm, we would refer them to the vascular surgeons. If not, we would repeat that study in 1 year. If there is still no evidence of tortuosity or aneurysm, we would repeat those studies about every 3 years. And those just the summary of my approach to a successful and good aortopathy clinic. It's the multidisciplinary approach. Again, it's the close collaboration with the surgeons, geneticists, imaging people, the individually tailored follow-up and treatment plan, practice that is based on valid and scientific-based evidence, and then importantly, shared decision-making with the patients and their families. And thank you very much for and I'm going to finish with that. Thank you very much for your attention. You can see our staff, our clinic staff here on the left would be the geneticists, and the cardiologists on the right would be our group of surgeons. And on the bottom, you can see my email, and I'm happy to answer any questions.
Thank you so much for that. You can stop sharing your screen and we'll get the questions up here now for Dr. Buber. Let's see. What is next after aortic root surgery for somebody who has Marfan syndrome, 23 years old? Is there any risk after 2 years of surgery? Maybe talk about the follow-up a little bit.
Yeah, good question. So after root replacement, we continue to do yearly screening, and we focus not only in the area that was replaced, we also focus on the other areas of the aorta that were not intervened upon. And so if it's usually the aortic root that has been replaced in Marfan's, so that we would see well on an echo, but the other areas we see less well on an echo, so the follow-up would probably be more with an MRI or a CT cross-sectional imaging. And based on that, it's going back to the algorithm that I've shown. If there's no change, we do a yearly screening. If there's any change, we do every 6 months usually.
Great, thank you. Here's a little bit of a question about urgency. So somebody just got their CT scan results back, and it did show a 4.7 aortic aneurysm. So how soon do you get it corrected? Once you hit a threshold, like, is there time? How do you judge that?
It's a great question. What I didn't mention is that for those, first appointments, when people come with kind of a borderline dilated aorta where they're like on the cusp of needing surgery and not needing surgery, what we usually do is we do refer them to see the surgeons, just so they get to know them and speak with them and discuss with them what does surgery involve, what does recovery involve. And once they get, I think, the general idea or the general concept of how they would recover from surgery and what it would entail, they can decide with us and with the surgeons when they want it done. Because, even when someone does not have a clear indication for surgery, many of our patients will tell us, I just want to get it over with. What does that entail? And it's not a huge mistake to do those operations, and when the cutoff is, when the numbers are slightly below the cutoff. And so that would be our practice. We would have those patients see us and then see the surgeons and have like a multidisciplinary discussion.
Great, thank you. We're going to have a whole focus on exercise later on today, but from your point of view, somebody's asking about their son who's had pexis surgery, takes Atenolol, does exercise at the gym, but there's people are scared about the exercise. And just for your point of view, again, we're going to talk about this more in depth later today, but what do you tell your patients about exercise and their imaging?
Yeah, I'm a big exercise fan. And I think that patients should be physically active and not give up exercise at all because they have, a connective tissue disorder. I take as much time as I need to and discuss with them why we recommend what we recommend in terms of avoiding heavy weightlifting and doing the Valsalva maneuver and avoiding contact sports, but also tell them what I think that they should do in terms of cardio type exercise. So it's totally fine to jog, and it's totally fine to bike, and it's totally fine to swim. And there is no reason to be nervous because those are safe exercises. We don't see complications that are associated to like jogging or swimming or biking. And even with the heavy weightlifting, it's not uncommon for us to see patients who are bodybuilders who come to us and have a dilated aortas. And the last thing that I want to do is to ruin their quality of life because, many times if those patients come in and I tell them to like stop doing heavy weightlifting, what ends up happening is I'm going to stop seeing them. They're going to find someone else to tell them that they can do the heavy weightlifting. And so we work on something like that we can work on together. We reach a compromise. So maybe less heavy weightlifting and more repetitions, maybe less air trapping and less of the Valsalva maneuver, but keep doing the weights. We try to find a compromise that would, be agreeable with the patient's quality of life, but also, not be very high risk for them.
Right. Yeah, so we're going to talk about that later more. The foundation also has a webinar November 9th, where two leading doctors will talk about the latest research in exercise, because there is new information coming out along the lines of what you're talking about. So thank you for that. Here's a question from somebody with VEDS, but I think this applies across all of these conditions. So if you have a cardiologist and vascular surgeon they were referred to, you trust that they know heart and vascular conditions, but they might not know much about Marfan, Loeys Dietz, or specifically VEDS. So how important is it to see cardiologists, surgeons, echocardiographers who are familiar with these conditions?
Yeah, I personally, I think it's very, very important. I think that, again, my other hat is congenital heart disease, and we deal with the same issues in patients with various types of congenital heart disease. You very much need to know what you're looking for. And you, for example, a cardiologist who's less familiar with VEDS would focus on the aorta because they're cardiologists and they're used to looking at the aorta, and they can tell you that the aorta is stable, but they forget that VEDS, or they're not aware that VEDS can include other vascular beds. And so we need to screen those other vascular beds as well, just like I showed. I think it's very important. I think that patients with connective tissue disorders should be seen by connective tissue specialists.
Yeah, I thank you. I think that we, the foundation is fully in support of that. And we do have an institution directory. So you know where there are some specialists in your area who are familiar with these conditions. Are there any requirements of cardiac surgeons to refer a patient to a genetics clinic after having surgical repair? Or, I mean, you're not a surgeon, but still, I mean, you work closely with the surgeons. And so somebody's having aortic enlargement, if they don't have a diagnosis, do you go back now to the genetics and say you need to go back to find out what's going on here, underlying cause?
That's for patients who did not have a genetic diagnosis and had a surgery?
Yes. That's what I believe the question is.
I think so. Yeah, I think we take the time to get like meticulous family history, but we're just cardiologists. What do we know? We need a geneticist to help us. And so we take the time, seriously, we take the time to get the family history. We do the full clinical examination. We look for the signs of a connective tissue disorder. But I think that, for someone who like has no other risk factors, so really no hypertension or not a smoker, not the other cardiovascular risk factors that I mentioned, younger age, not like a bodybuilder that lifts 500 pounds every day or something. Yeah, I would think that I would rely on myself, but I rely, I think, more on the geneticist to make that diagnosis. And so in the vast majority of the cases, I would probably refer them to see a geneticist, yes.
Because it would have implications for other family members, potentially.
Absolutely. That's exactly the reason.
Can you just take 2 seconds and go back to your explanation before about heavy weightlifting and connective tissue conditions? So why is that not a good thing? Somebody's asking.
That's a good question. I think that, going back to, we try to base everything that we recommend on like clinical evidence. And the clinical evidence is really not that robust, but there are some reports that show that heavy weightlifting, especially when we're holding the air inside the chest and we give those last few pushes while bearing down, it's called the Valsalva maneuver, really increases the intrathoracic pressure, so the pressures inside the chest wall. And when you're thinking of aortopathies that are related to connective tissue disorders, the wall of the aorta is thicker for various reasons. And so any acute increase, and importantly also repetitiveness of that acute increase in the intrathoracic pressures can increase the chances of badness, dissections and ruptures and so on. This is the theory. I'm going to say again, the data to support that is out there, but it's kind of limited. And of course, it's like, other than getting animal models, you're not going to do like human studies and check when dissection happens, right? And so we base our decision making on some case reports and our logic, I guess, of what increases intrathoracic pressures. And so again, going back to the question before and what I said about reaching some compromise, I think that we need to be very thoughtful in how we restrict our patients, and we need to be thoughtful in what they want to achieve, what are their exercise goals. And so I think my approach and my peers' approach is to, yes, recommend not to do those repetitive, very, very heavy weightlifting with that Valsalva maneuver, because we think that those increases in the intrathoracic pressures make patients more prone for dissections, but also tell them that the data out there is not like super robust on that.
And their mental health is important as well.
Absolutely, absolutely.
Last question for you. What's your opinion on caffeine? Not generally you, I mean, maybe you had your coffee this morning, but in connective tissue conditions. I know I did.
I think caffeine has been, well, I'm going to start by saying that in general, there's data that shows that up to 5 cups of caffeine per day are healthy in terms of reducing the blood pressure, reducing the chances of diabetes, reducing the chances of strokes and heart attacks. There is limited data on patients with connective tissue diseases and aortopathies, but I think that we're very much moving away from that dogma that caffeine causes acute increase or surges in the blood pressures and causes arrhythmias and all those things. There's a little bit of a caveat next to that. We know that there's some genetic conditions that kind of make people a little bit more prone to develop higher blood pressures and arrhythmias after ingestion of caffeine, but those are extremely, extremely rare. And so in the vast majority of the cases, I have absolutely no issues with caffeine ingestion.